At the outset, I would like to thank Dr. Somashila Murthy for this kind invitation and opportunity to present here, and to AIOC for this DreamCon after a very long time. We are very excited to be back in action. And today I will be taking you through the acute management in ocular chemical burns, where things can actually make a difference. So when we talk about chemical burns, it could actually range from a wide variety of spectra, like it could be liquids in the form of acids or alkalis, or it even could be due to fumes in lab workers, or it could be holy color injuries or firecracker injuries, tuna burns, lime burns, which are there, cement injuries, and the recent ones like sanitizer burns, or these days some atypical burns like smartphone battery blasts, which we published, or the cosmetic cream being instilled into the eye, or very recently the do-it-yourself experimentations on YouTube by kids which are unsupervised at home, and sometimes the chemicals go into their eyes. These could be one-time insults, or they could be chronic installations in the form of unidentified eye drops which have been prescribed by quacks, and these can result in extreme injury to the ocular surface, something like this, which a bilateral burn of both the eyes actually, where there is limbal as well as tarsal ischemia and necrosis. So our management focuses on the acute phase to save the globe, basically to decrease the inflammation and to save the globe. There are various prognostic classifications which are present, which help us to manage these cases. And most importantly, when we start our management, this is actually an ophthalmic emergency, and wherever possible, whenever possible, always try to wash or irrigate. So in pre-hospital settings, this could be with tap water, or it could be in the hospital settings with whatever fluid that you have. There could be ideal solutions also available which can be utilized. So the basic aim is to get rid of the offending or the inciting agent, and also to debride whatever is impacted in the ocular surface or in the fornices. And also along with that, we try and assess the epithelial defect to know what the prognosis of the case is and how to manage further. So this is the typical emergency kit that I recommend all of us should have in our departments, wherein a simple kind of a setup can be there with an IV line there, and an open IV line with the fluid there, and topical anesthetic drops along with a Desmas retractor. The toolkit also includes pH paper to know what is the end point of irrigation, and a fluorescein strip. So this is a simple a kit which can be made accessible, and everybody in the department should know how to use it and where it is kept. So this is just a basic video of trying to show the irrigation in the acute phases. Always try and assess where the debride, where you have to find the impacted material or any tuna particles or any other chemicals which might be impacted there. Always look into the fornices, make the patient comfortable. If there is a plaque which is impacted, then we have to remove that. And that said and done, it has to be very aggressive in the beginning itself. We may have to remove the speculum and inspect the fornices, the superior as well as the inferior. Copious irrigation is also continued along with that. And then the amniotic membrane, depending upon the area of epithelial defect, can be placed. If it's just a simple corneal epithelial defect with no limbal ischemia, then a BCL can be placed. Otherwise, if there is some amount of less than 50% of the bulbar conjunctiva, which is again implicated, then we can place amniotic membrane graft. If it is more than 50% of the conjunctival involvement, then we can also do an alloslet along with it. And if there are primary corneal burns or melts happening, then also alloslet can be used. And along with that, if there's tarsal burn, then we might have to resort to mucous membrane grafting. So always make sure that the impacted material is removed. Otherwise, there might be later these kind of intrastromal plaques which are very difficult to handle. So these are the types of the spectrum of injuries to the limbus also. And once we've assessed the epithelial defect, also we look for the ischemia to get simultaneously. And basically we try and assess whichever area is ischemic. And here if you see, we've debrided the necrotic material and we're trying to rub the area and see if it's bleeding properly. If not, then we have to do a Tennant's advancement procedure. Here we are trying to fashion a conjunctival pedicle flap also to restore the vascularity. So any ischemic area that you find needs to have a restored vascular supply. This is the Tennant advancement, and you have to basically suture it and anchor it. 1 to 2 mm thick Tennant has to be anchored towards the limbus with either 6-0 vicryl, interrupted sutures, and then over that we have to place the entire amniotic membrane. Another case of a child where on touch, again with the forceps I'm trying to move the globe, does not have any bleeding, and so we had to do a 360-degree Tennantoplasty. Next, we have to look at the exposure which is there, and there should be very little threshold for performing an tarsorrhaphy. For example, in this holy color injury boy, where we had performed multiple amniotic membrane grafts along with tarsorrhaphy. So basically, it decreases the exposure by decreasing the surface area, and it starts to bring the tarsal vasculature closer to the surface, and it also decreases the lid-related keratopathy by decreasing the blink Viper syndrome, and that helps in healing of the epithelialization of the surface. So 5 months later, we were able to achieve epithelialization. Then the most important part becomes your topical steroids, which are to control the inflammation, and that actually basically decides what is the prognosis which is going to happen. So in the first 1 week to 10 days, it is of prime importance to give topical steroids. Sometimes even oral steroids are necessary. And if you feel that there is an area of melt, then we might even apply amniotic membrane graft, and that is how we manage. And the supplementation is along with doxycycline orally as well as ascorbate. Simultaneously, we also have to monitor the intraocular pressure, which might be high because of the direct damage by the chemical to the trabecular meshwork or by the steroid use, and that might need anti-glaucoma therapy. And sometimes an ominous sign is a hypotony because of anterior segment ischemia, which might later lead to phthisis bulbi. So we have to monitor that too. This is a typical post-operative regimen with a topical steroid, which is frequently given, along with preservative-free lubricants, an antibiotic, which is broad-spectrum and epithelium-friendly, topical cycloplegics, oral doxycycline, and vitamin C, along with or without anti-glaucoma therapy. So once we have stabilized the surface in the acute phase, and the picture looks like this at the bottom, I think that is considered as a success because we have successfully saved the globe. And now the process, the patient is ready for the next step of ocular surface reconstruction in the chronic phases and later visual rehabilitation. So I think all of us should strive for a good acute stage management to give a good prognosis to the patient in the later phases. So this is basically our article which had been published for management in the chronic phases. Now I'll just quickly take you through the Stevens-Johnson syndrome patients or the management. So Stevens-Johnson syndrome, or along with toxic epidermal necrolysis, which is the most severe form of the disease, is basically a spectrum of severe immune-mediated vesiculobullous mucocutaneous disease. It might affect the children as well as adults, so we have to be very careful. It is broadly characterized into an acute phase as well as a chronic phase, and both of them have characteristic clinical features, points of presentation, management, and prognosis accordingly. So in the acute phases, you might be asked to be treating the patient in the burn ICU or in ICU settings along with dermatologists, and the patient might be in a very morbid condition, whereas in chronic phases, the patient might come by himself or being brought into your OPD for further management. And accordingly, we have to take the necessary actions. So systemically, if you see, the disease might vary from mild rhinorrhea to very severe vesiculobullous generalized erythematous disorder with skin sloughing. And in the eye, basically what you have to see is look for the entire ocular surface, And there might just be a mild conjunctival hyperemia, or there might be entire sloughing of the ocular surface along with lid margin involvement. So a basic fluorescein stain can help you diagnose any of these, and you have to also look for pseudomembranes or membranes. So basically, if there is any corneal or conjunctival epithelial defect along with a lid margin involvement or presence of membranes or pseudomembranes, then we have to be very careful, and that necessitates the procurement or the application of an amniotic membrane graft. And the progress of this disease can be very rapid. Within hours, it can progress from something like this to the total sloughing. So we have to be very careful while monitoring these patients. And a simple amniotic membrane bedside can save the eyes of these patients. So this is the Harvard study group, which says that if there are defects along with pseudomembranes or membranes present, then immediately we have to apply the amniotic membrane graft, and this is their technique, which is very useful. So initially we just anchor the upper part of the lid margin to the amniotic membrane graft with these stay sutures, spread the entire amniotic membrane over the surface, and whatever anesthesia the patient can tolerate, we can just start with that. If it's a periburbar or a facial block or a topical anesthesia, whatever the patient is comfortable with, we have to do this procedure. Then there's a symblepharon ring which is being made by the infant feeding tube number 6, and the inferior part of this is being pushed into the fornix, taking care not to split the amniotic membrane. Then the superior part is being pushed into the superior fornix, and then the entire amniotic membrane is again sutured, taking care to drape the lid margins along with it. So this is a simple, basic amniotic membrane technique. There are variations to this. There are these symblepharon rings which can be layered with the amniotic membrane and simply put into the eye. So a simple procedure like this can help in taking care of long-term complications. So this amniotic membrane can basically help in saving the visual acuity, can help in decreasing the limbal stem cell deficiency, the later formation of lid margin keratinization, symblepharon, and all these complications later. So this has to be monitored till the patient is in the hospital and even later on. We have to make sure that any membrane or pseudomembrane that was present has to be washed off. There has to be regular saline rinses, and topical steroids have to be given in the form of eye drops as well as ointments along with frequent lubrication. So that's very important for lid position. We have to make sure that there is no exposure because of lag of thalamus, because these patients are sometimes in the ICU and their eyes are exposed. So in the chronic phases, around 60% of the patients when they come to us have severe corneal morbidity, and then they come to us with chronic cicatrization conjunctivitis features, and it is very difficult for us to diagnose what was the cause initially. So there are few clues which we can actually utilize, and if you see, there's a posterior migration of the mucocutaneous junction of the lip along with loss of nails, and then there is ocular and the entire body's pigmentation changes which are present, and based on these, this is the loss of finger and toenails. And based on these, as well as the chronic ocular findings of dystichiasis, meibomian gland orifice blockage, along with lid margin keratinization, there has been a scoring system which can help us diagnose whether this chronic cicatrization is because of SJS or not. This is important because when we diagnose it as for SJS, the surgical management becomes very important, whereas if it is due to other cases like OCP or MMP, then the medical management in the form of immunosuppression is then the mainstay. So here there is a plaque of lid margin keratinization in all the lids, and this actually causes the lid viper keratopathy and the ocular surface destabilization. So basically, a simple mucous membrane graft over the lid margin can salvage this eye. Here it's beautifully draped, and there's a good anterior edge apposition here, which saves the eye. And along with this, in this photophobic patient, we had done lid margin mucous membrane grafting along with a scleral lens placement, and this has really improved his presence. Now, along with that, there might be a presence of dry eye, and in later stages, it might also lead to ocular severe dermalization. So if there's a mild to moderate dry eye, we can do punctal cautery along with autologous serum, and then topical cyclosporin can also be given. And minor salivary gland transplantation can be a method to salvage in certain cases. The ocular surface inflammation is basically taken care of by the systemic immunosuppression with azathioprine or cyclophosphamide in severe cases. Other ways to stabilize the surface, which is melting, could be the application of tissue adhesive along with bandage contact lenses, a Gunderson flap.
Can we summarize, Purvasha?
Yeah,
We are
sure.
running a little.
So Comet and slit. So these are the applications of tissue adhesive. Multiple amniotic membrane grafts which have been done. This was a case of a tenon patch graft. The PKs that are done in for tectonic purposes do not epithelize well, so we have to monitor those too. And there are issues with the surface with the ocular flora. There might be MK, which is present, microbial keratitis. For visual rehabilitation, we might have to have very specific ocular surface procedures before the cataract surgery is done, because the view is going to be like this. And the end stage of management is keratoprosthesis. So this was the case in which we had to do a primary keratoprosthesis after confirming it on a diagnostic endoscopy. And again, we might have epithelialization issues. And type 2 K-pros along with modified osteoodontokeratoprosthesis along with other types of LVP K-pros and all might be needed. So all these severe cases can still be salvaged in the acute stage by the simple application of an amniotic membrane graft is what I have found. So that was the message that I wanted everybody to take home. Thank you.